Hello, everyone. Welcome to the Preemie Chat, and thank you so much for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, as known as CPBF. We are a charitable organization, and our mission is to empower families of premature babies through support and education. This Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us their knowledge and experience. Also, on our website, canadianpreemies.org, parents will find all kinds of resources and support. And today, we're going to talk about supporting feeding for preemies in the early years. Dr. Walton's talk will focus on eating behaviors, caregiver-feeding interactions, and the dietary intakes of children born preterm. She'll touch on the assessment of peak eating versus problem eating and practical tips for reducing mealtime stress. And I have her joining us live. Let me make here from Toronto, Dr. Kathryn Walton, who is a registered dietitian and assistant professor of applied nutrition at the University of Guelph. Her work examines parent-child interactions related to feeding, eating, and family mealtimes while considering how parenting stress and family functioning might impact young children's health. Dr. Walton's current focus is supporting feeding practices and health eating among children born very preterm and with neurocognitive impairments. She's passionate about helping parents raise happy, healthy eaters. Dr. Walton, thank you so much for joining us here today. I am very excited about this talk because it's also something very personal to me.
Thank you so much for having me. It's really a pleasure to join, and I'm looking forward to the questions after my talk as well.
Yeah, so let's share your presentation here. For all of you watching us live today, please do send your questions, your comments, share your experiences with us, and we're going to address them at the end of her presentation. Dr. Walton, the floor is yours.
Wonderful. So as Fabiana said, today my talk is going to be on supporting feeding for preemies in the early years. I recently joined the University of Guelph as an assistant professor, but much of the work that I'm going to present today was conducted during my postdoc at the Hospital for Sick Children. And so in today's talk, we're going to review what the research tells us about preterm children's eating and feeding in the early years. And then we're going to chat a little bit about how we define picky eating versus problem eating, how to understand the differences, and when and how to seek help if you're feeling like you require more support. And then we'll end the presentation with some really practical tips for helping reduce mealtime stress for all preemies. And so by the age of 5 or 6, children will form eating habits and food preferences that last a lifetime. Most of these are learned, but some are innate, and genetics certainly play a role. And there's long-standing research to suggest what the birth parent eats during pregnancy not only influences children's taste preferences, but may also influence children's growth via effects on appetite. Then early after birth, eating is very much a neurodevelopmental process that requires a coordinated suck, swallow, and breathe mechanism, all while taking in the sensory inputs from the environment and the food itself. So there's lots going on for an infant to learn. As infants master the art of oral feeding, psychobehavioral aspects of the feeding environment become a more important influence on children's eating and their self-regulation. Ideally, even infants should have autonomy over how much they eat, and research suggests that babies born preterm are also able to start and stop eating in response to their hunger and satiety cues, or their hunger and fullness cues. However, of course, both parent and caregiver and family factors such as culture, family resources, and child temperament shape early feeding interactions and thus the development of eating habits and food preferences. Oops, did I skip a slide? I skipped a slide. Okay, so now That presents a really linear approach to the development of children's eating behaviors. But as many on the call might reflect on their own experiences or experiences they're currently having, I really want to highlight that children need to learn to eat, and caregivers and parents need to learn to feed. Kids don't come with a manual, and the development of healthy eating behaviors can sometimes be challenging and take time. And so both eating and feeding are bidirectional, and some children do take longer to master the skills necessary. And so parents can help children master these skills by allowing opportunities for children to develop their oral motor skills, so their chewing and swallowing and the coordination of their lips and tongue and mouth to get to swallowing. And also through food parenting practices and sharing their family culture and traditions around food. And so you may be wondering, well, what is food parenting? And so food parenting are practices that are used to influence what and how much a child eats. And so the research describes food parenting in sort of three main areas. So the first there is coercive control. And so this refers to a parent or caregiver's pressure or intrusiveness in relation to the child's feelings or thoughts or behaviors around food. And I want to note that this is usually very well intentioned. So it may be encouraging a child to eat 3 more bites or using things like food as reward. So I have an example there. If you eat your broccoli, you can have ice cream. Then there's structure. And so structure refers to things we can do to set up the mealtime to facilitate children's eating development. So that may be reflective of eating meals as a family, or having rules around when meals are eaten, or screen use during meal times. And the third category of food parenting is what we call autonomy support. And this refers to parents or caregivers' roles in allowing children independence during eating. And so this might involving children during meal prep, or negotiating the types of foods that end up on the menu, or what foods the child should eat without pressuring. Now, I do want to note that this body of literature is not without limitations. And the biggest is that it's mostly been conducted among term-born, typically developing children. So this body of literature sort of reflects the average child. And so my research is really focusing on the food parenting practices that might be most supportive of children who are born preterm. And so children who are born preterm, often they experience organ immaturity, birth complications, and medical interventions such as tube feeding that, while certainly life-saving and very necessary, do challenge the development of the necessary skills for the successful initiation and advancement of oral feeding. So it's not surprising that infants born preterm do experience high rates of feeding difficulties while in hospital. And looking at these two photos, you can see just how different the early feeding experiences of a baby born preterm versus the other picture is a term-born baby. And so, unfortunately, many preterm infants are also discharged from the hospital with an uncoordinated suck-swallow pattern, and support post-discharge can be difficult to access depending on where you live and what resources are available. Research also suggests that babies born preterm experience higher rates of diet-related chronic diseases in adulthood than their term-born peers. And nutrition isn't really a focus post-NICU discharge, but that's something we're certainly hoping to change and work on. And so as part of my research, I really got interested in, well, what are the eating behaviors and the caregiver feeding interactions and the dietary patterns of children born preterm? And so what my colleagues and I did is we conducted a systematic review and a meta-analysis to describe these factors among children who are born preterm during late infancy, so between the ages of 6 to 12 months, and early childhood, so greater than 12 months to 7 years. And we also sought to clarify whether these skills or challenges differ from term-born peers. And so as part of this study, we looked at 3 different outcomes. So as I said, we looked at eating behaviors and skills, which we defined in 2 different ways. So we looked at oral motor skills, which are skills such as sucking, chewing, swallowing, and then concerns around that. So gagging, choking, those types of things. And we also looked at challenging eating behaviors. So things like food refusal, picky eating, tantrums during meal times. Our second outcome was caregiver-feeding interactions. So looking at how caregivers and children interact during feeding occasions or meal times, and looking at food parenting practices that are used. And finally, we looked at dietary patterns. So we looked at the exclusivity of human milk feeding, timing of introduction to solids, and diet quality. So that was, again, between the ages of 6 months to 7 years. And so in terms of oral motor difficulties, what we found overall is that children born preterm were 2.8 times more likely to experience an oral motor difficulty, such as chewing, swallowing, a gagging concern, or inappropriate lip or tongue or jaw coordination in comparison to their term-born peers. And when we looked at the preemies themselves, without the term-born comparison, we found that overall about 34% of preemies do experience these challenges. And again, they're 2.8 times more likely to experience them than their term-born peers in those early developmental years. And so when we look at those eating behavior challenges, what we found is that overall, preemies, about 18% of them seem to exhibit these eating behavior challenges, such as food refusal, tantrums during meals, or selective eating during those early years. And when we compare them to their term-born peers, they're about 1.5 times more likely to exhibit one of these challenges during those early developmental years. So lots of challenges were presented in the literature in terms of eating and feeding. And so when we looked at the caregiver feeding practices, this body of literature was really conducted in many different ways. And so instead of doing a meta-analysis, what we did is we narratively reviewed this literature. And what we found is sort of 3 main findings. The first was that caregivers have significant concerns about their preterm child's eating and dietary patterns. And while feeding, many caregivers seem to express feelings of stress, anger, and frustration. When it came to the specific feeding practices that caregivers reported using, many reported using unstructured meal environments. So for examples of those from the literature, where preemies were less likely to eat with other family members and less likely to have sort of a structured meal schedule. There was also frequent use of food as reward, either for eating other foods or for behavioral control. And the caregivers of children born preterm were less likely to agree that children can guide their own appetites than those of term-born children. And then finally, in terms of mealtime interactions, what we found is that there was between caregivers and children and infants who were born preterm, there was low reciprocity during feeding interactions. So less sort of connection and flow between the caregiver and the child. And there were reported to be lots of conflicts during feeding. And then our third outcome, in terms of dietary patterns, again, this body of literature was also conducted in many different ways and looked at many different aspects of children's diets. So we also narratively reviewed this literature. And what we found is that infants and children born preterm are overall not seeming to meet dietary recommendations. The literature suggests among preterm babies that there's a low initiation and exclusivity of human milk feeding. These babies seem to be introduced to solid foods earlier than recommendations. And overall, during the childhood years, so sort of greater than 12 months to 7 years, the literature suggested poor diet quality among preemies. And so building off this work, our research is really hoping to help support positive feeding interactions, the development of healthy eating behaviors, and dietary intakes. And so this research really gives us a starting point in terms of where to go next. So the second part of my talk today, I wanted to chat a little bit about picky versus problem eating. And so when we think about picky eating, some of this is developmentally appropriate. Across research, when you ask and when you look at any study, about 14 to 50% of any children are considered by their caregivers to be picky eaters. So it's very common, and some of this picky eating is actually developmentally appropriate. And so picky eating tends to peak around the age of 3, and this is because at that time, children's growth rates slow relative to infancy, appropriately so, and children start to develop individual preferences and autonomy at this age. It's also sort of maybe historical is not the right word, but back in cave people days, children might refuse new food the first time they're offered it because it may have been poisonous. And so some of that maybe has stayed with us. That sort of initial worry about new food might actually be protective. But there is a difference between picky eating and problem eating. And so on the next slide, I'll give you some tips on how to think through that. So on the left there, we have our picky eaters. And so picky eaters are defined as children that do have a limited range and variety of foods in their diet, but they do have, if you were to count up all of the foods that they eat, there would be 30 or more foods in their total repertoire. They may go through times of food jagging where all of a sudden they don't like, name X food for a few weeks, but that food tends to come back into their repertoire after a few weeks. These children will eat at least one food from most texture groups, and they will tolerate new foods on their plate most of the time, and they maybe touch or taste the food, but they may not eat it. These children often eat different foods than family members at mealtimes, but they do eat together with their family members. And these children do have the ability to learn new foods, but it does take some steps to learn. And what the research tells us is that children who are picky eaters typically do outgrow these behaviors with time and with some gentle supports from caregivers or healthcare professionals. On the right, however, we have our problem eaters, or our children that we want to look into things a little bit more and certainly seek support and help. And so with these children, there's certainly a restricted range of food and variety. And so if you were to count up all the foods in these children's diets, there would be 20 or less foods. Food jagging, so again, where foods all of a sudden are not preferred, is quite frequent, and those foods don't tend to end up back on the child's list of preferred foods. These children refuse entire categories of foods or textures. There's a lot of crying, screaming, and tantrums when new foods are presented. They almost always eat a different set of foods from family members, and typically, or sometimes they eat at different places than family members, so at a different time. And these children can also learn to eat new foods, but it takes a lot more steps, and it is much harder. So other things I like to consider when I'm chatting with families about whether their child, we might be more concerned than just sort of our general picky eating. Things I look at are poor weight gain or ongoing weight loss, if there's ongoing vomiting during or shortly after meal times, any reflux problems. The research suggests that about 1 in 10 children born preterm do experience reflux, so fairly common. If there's ongoing respiratory issues or frequent upper respiratory infections, this might be due to aspiration, so we want to check in on that. If there's frequent gagging, choking, or coughing during meal times. A quick note on gagging. Initial gagging is okay. It's really protective for newborns, and it prevents the ingestion of foods that are too large. Typically, as lumpier foods are introduced, that gag reflex tends to decline. However, it can still be seen in babies, older than 6 months corrected age, certainly, and typically declines by 12 months, but it never disappears completely. Even adults have a gag reflex, but really where we're concerned is the frequency of gagging and how often it's happening. I also look at caregiver stress about feeding. So anytime there's stress, I say, let's seek help and let's chat about it. If meal times are taking over 30 minutes, that's a bit of a red flag to me, and we can chat about how to support a shorter meal time. I also look at things like rigid eating rituals. So this might be things like the child only allows one person to interact with them or feed them, or maybe they have to have distractions before eating, like a TV or a tablet. And then the final thing I like to just chat about is a possible tongue tie. Not all children who have a tongue tie have symptoms, but it may start to present with introduction to solids if it hasn't before. And so just chatting with your healthcare provider potentially about that. And so I do want to chat a little bit about where to go for help. And so we've looked at the definition of picky versus problem eating, and wherever your child or the child that you're working with you feel falls, I think it's worth reaching out for help. We feed our children, multiple times a day, and if each of those interactions is stressful and we're worried about our child's potential growth or nutrient intakes, seek help. And so it's really an interdisciplinary team that can support the development of children's nutrition and eating habits. The World Health Organization framework for the classification of functioning, disability, and health addresses 4 main feeding domains. And so challenges might occur in terms of medical, nutritional, feeding skill, or psychosocial. So depending on where your child's challenges fall, chatting with their primary care provider or physician who knows their medical course well can help guide referrals and next steps. But some of the professionals that you will probably see or should ask to see would be a dietitian who can help understand nutrient needs and eating behaviors to support healthy growth and development, an occupational therapist who can help with oral motor skill development and sensory therapy, an SLP who will help with a swallowing assessment to ensure that your child is safe for different textures. And it's important to note that early language development and eating development can be related. So getting support for early language development can be really helpful. A behavioral analyst is certainly a good profession in your toolbox. They will evaluate the environmental factors to support positive meal times. They'll work through strategies to reinforce desired eating behaviors as well. And then finally, a gastroenterologist would assess whether there's physiological or structural anomalies that are contributing to challenges. Okay, and so to wrap up the presentation, I know we've been chatting quite a bit about feeding difficulties and how to define them, but I wanted to leave you with some practical tips to help reduce meal times. And so these are tips you can start at home, while you're waiting for referrals for more support, or depending on the challenges, some of these you might start to see changes by implementing them. Every child's different. And so these are really just tools in your toolbox. Not all of my suggestions will work for every child, but these are some things that may be supportive. And so the first and foremost, for children who are oral feeding, we do recommend starting solids between the ages of 4 to 6 months corrected age. We look for developmental readiness for solids. So each child will be a little bit different in terms of when they're ready. They're ready when they can sit up on their own, when they have good head and neck control, if they turn their head away when they're full, they show interest in food, and they're grabbing objects and putting it in their mouth. And I do want to note that infants that are continuing to require medical supports, such as oxygen therapy or tube feeds post-discharge, may have specific recommendations from their healthcare team about starting and supporting complementary feeding. So if you're unsure, reach out to your team and ask. The next thing I want to chat about, and you may have heard this, this number floats around quite a bit, but research suggests that it takes about 15 to 20 times for a child to be exposed to a new food before they try it. Now, this is an estimate. Some children, it may take more than 20 times. So just knowing this, I think, can be helpful, that trying new foods and learning to love new foods does take time. And when we think about exposure to new foods, I want to highlight that eating and actually swallowing the food is sort of the last step on that. And so if we have kiddos that are really nervous around new foods, we can start really basic by tolerating the food. Can we start with being in the same room as the food and maybe working towards having that food on our plates? Once it's on our plate, can we start to maybe interact with that food? Can we pass the dish to another family member, or can we stir it around with a plate, with a fork on our plate? From interacting with it, maybe we can smell the food. So maybe it's in the same room as us, or maybe we're feeling brave and we can bring the food close to our nose and have a smell. From there, maybe, we'll touch the food with our hands, maybe touch it to our lips or our cheeks. That then, finally we're getting to tasting. Tasting can be licking the food from our fingers. Maybe we'll take a small bite, but we might not, swallow it. And then finally we have eating. And so I just want to highlight that some children will move through these stages slowly, and some will move through them fast. But I hope it just gives you some ideas about how we can start to introduce new foods to our little ones if they're hesitant, and just to start slow. In terms of texture progression, safety is paramount. And so we do, if you're concerned about safety, certainly reach out to your healthcare team. Ensure that your child is safe for each of these textures. But we do want to encourage, as children are safe to progress through textures from purees all the way to, whole foods. And I've provided some examples here. In terms of fruit, we might start with a pureed fruit, then it would be mashed, then naturally soft pieces, and whole fruit products. And at the bottom here, I've provided examples, like those are green beans, of what that might look like in terms of texture progression. But as children are safe to, we do want to ensure that we're offering a variety of textures, because even learning with those textures and moving them around our mouth helps children develop oral motor skills. It's important to consider children's eating positions, so how they're seated wherever they're eating. These are two clips from some of my own research. We have 2 kiddos here. And I just want to highlight that it's important to make sure children are seated properly with their feet on the ground or a footrest so that it supports their torso to properly eat, and it keeps them comfortable. Even high chairs aren't necessarily set up properly. A lot of the traditional high chairs, babies are sort of leaning back, which doesn't support proper swallowing. So get them seated right up. And so I really like this picture of this kiddo here. This kid's actually sitting at a coffee table. And so this family's table was actually too high for him. And so we worked together to get him sitting at meals at the coffee table such that he was properly seated. And it went a long way in terms of making him feel comfortable and confident to eat. And then very quickly, some other tips for positive meal times. As much as possible and appropriate with your child's development, allow them autonomy. So let them choose their spot at the table, the color of their plate, the vegetable being served within reason. And, you can also do things like pairing their favorite foods with novel foods to help increase the chance that they'll try it. In terms of mealtime schedules and transitions, it's important to have a regular mealtime schedule to allow children to come to mealtimes ready to eat versus grazing throughout the day. I also always suggest not doing the child's preferred activity right before mealtimes because it can be hard to transition to eating and leave that favorite activity. In terms of your meal schedule, typically having meals and snacks about 3 to 4 hours apart, and meal occasions no longer than 30 minutes is what we suggest. And then as we've been chatting, offer a variety of foods and textures during meal times. I also suggest limiting screens. This allows family members to connect. And it also helps children listen to their own body to know when they're hungry and full. As much as possible, try and eat together. This allows children to learn family food rules and cultural traditions. It also helps them learn what's appropriate mealtime behaviors. And by watching you eat new foods, it tells them that, oh, this is a safe food. I see my loved one eating this food, maybe I'll try it too. And then finally, it can be hard, but listen to your child's cues about hunger and fullness and try to avoid pressuring them to eat as much as possible because it sort of amps up that frustration and both parent and child can come to the meal times feeling already like, oh gosh, I'm going to be pressured or I'm going to have to pressure. And avoid food rewards. Non-food rewards such as stickers, spending time together, activities, those things are great. Food rewards often actually don't help increase likeness for that disliked food. And it can be very hard to eat the disliked food without rewards later on. And so to wrap up, I just want to say that we still have a lot more to learn. So stay tuned to our work. We're researching how to mitigate feeding challenges early among children born preterm. We're looking at which food parenting practices are most supportive of preemies' healthy eating and growth. And we're also looking at ways to integrate supports into NICU follow-up care. I've added a slide here with some additional resources and supports in terms of feeding clinics and behavioral analysts that I know of that do offer care around the GTA as well as virtually if you are looking for more supports as well. And then finally, I do want to acknowledge my wonderful research team and some of the funding that we received to do this work. So thank you so much for listening, and I look forward to your questions.
Hi, Kathryn. Wow, that was so great. And you answered so many of my questions.
Oh, wonderful.
Amazing presentation. And so many of us Preemie parents face those challenges, and you address so many of them. It's like, okay, what can we do? But I'm going to bring questions from our live audience first. And you did address that in your presentation, but I think this is a question that we always get asked. Do we follow corrected age while you transition into puree into solid? Thank you, Jasmine, for joining us here today.
Yeah, that's a great question. The Canadian Pediatric Society certainly does recommend corrected age in terms of introduction to solids. But what research tells us is really looking at that developmental appropriateness. And so less so than, today my child is 5 months corrected age, we're going to start solids. Really looking at the child's cues in terms of, are they able to sit up alone unassisted? Are they interested in bringing foods or objects even to their mouth? Do they have good head and neck control? Those are the things that I would look for first and foremost, and certainly chatting with your healthcare team too, in terms of what your child's medical course has been like and what they might suggest. But corrected age is recommended.
Yes, actually, you just answered the question, but I think I want to make a comment here too. Jasmine asked this checklist on readiness. Does it require to completely follow? My child is able to hold head and grab items to mouth, but yet to sit independently. Can I start solid? And I will add to that because my son had cerebral palsy. He wasn't diagnosed yet, but he couldn't sit. And we want to start solid. So we did have a special chair that had full support for him to sit, so we could introduce solid. But I just want to leave it to that and let you make some more comments on this.
Yeah, for sure. And that is really, that checklist is sort of a guide. And certainly depending on each child's ability, some children will never be able to sit up fully unassisted. It doesn't mean that they can't start solid food. So as Fabiana was saying, thinking about, if that's your child, about the proper supports, that they're in a chair that supports them to sit up. What we want to avoid is having the child in our arms, cradling them and feeding them that way. We do want them sit. And the reason we want them sitting up is so that when they start to have that gag reflex initially, they're safe with that, right? So that gag is okay as long as they're still, taking oxygen in. But when they're not seated up properly, that's when we can be quite concerned about choking. So I hope that answers your question. But typically we would, for children that are able to sit up, thinking about those milestones, but it is a guide.
Okay, that is great. So my question to you is, because we did talk about a lot of signs of the babies being preterm and have some challenge or aversion and so on. Well, my question is, when parents need to look for help, because there is a lot of, okay, let's try, and then you introduce today, and then you give a break, and then introduce the solids again, another texture another day, but nothing is working. When you say, okay, I'm giving up, I need help. So when to go for the help and who to look for help first, because you did mention to go to your family doctor, pediatrician. And a lot of parents share with us, a lot of times community doctors are not fully aware of the unique needs of the preterm babies.
Yeah. And I think that's a big challenge, and something that my work, I'm trying to work through to change that, so that the first line of care is more aware of these feeding challenges. But what I would say in terms of wondering when to get help is the sooner the better. And so there's no harm in saying, you know what, I've started solid foods, I'm feeling a bit nervous. Let me reach out to a healthcare professional and just see. And the best thing that can happen is that person says, you know what, you're on the right track, keep on that. Or they can say early on, you know what, here are some things that we might want to change to support earlier. And so I would say, if you're at that point where you're sort of wondering whether you should ask for help, it doesn't hurt to ask. And I would just encourage that the earlier, the better. I'm always happy to chat with families. And it's, if I can be a cheerleader and say that, what, you're doing a great job, I'm happy to do that, right? Because kids don't come with manuals, and they're all different. Even if you have an older child, your new child or your new baby is a total individual, and some of those experiences don't necessarily translate. So I would say earlier, the sooner the better. In terms of who to go to for support, a lot of these professionals, some of them do require referrals. And so I think going to your family doctor if that's your first line of care as an advocate for yourself, and saying, I would like to see, if you've identified, I'm really nervous about whether my kid is meeting all their nutrient needs, go to a dietitian and say, I would like a referral to a dietitian. Or if you're feeling like it's more of a behavioral thing and your child seems to eat different foods from different food groups, so maybe we're not as concerned about nutrients, but it's more about like, it's a big struggle. They eat it, but it's like, it's really a struggle. That's when I might chat about, is it a struggle because it's sensory and maybe we want to see an occupational therapist or maybe a behavioral analyst. And sometimes those behavioral analysts, they have multidisciplinary teams. So you might actually be able to see all of those professionals wrapped up. Your neonatal follow-up care, if you are being seen by one of those, by a clinic, they would probably be best suited in terms of how to guide your next referrals, because they're really familiar with what your child's medical course has been like. If your child had any gastro or GI surgeries early on, or any concerns that way, I would certainly reach back out to the gastroenterologist just to make sure there's not an ongoing structural or physiological issue as well. So think about what supports your child had early on or what interventions they had, and that might also help guide. Each child is an individual, so it's hard to say exactly, go to this person first. But I hope that answers your question a little bit.
So can we talk a little bit about the behavior analyst? Because from my experience, my personal experience with my son, who he only ate pureed food until the age of 6, I only heard about the behavior analyst when he was 6. And I had gone to several OTs. We did speech and language pathologists. We did everything under the sun why this child could not eat food at any other texture. And it was at a conference that I heard a behavior analyst talking about the challenge of preemies with feeding and diapering and how a behavior analyst could help. So why don't we know about that? So I just want you to shine a little bit of a light. What do they do? And they are not only professions that work with kids on the autism, because this is an impression that most people in the community have.
Yeah, and so I think that's great to highlight that as behavioral analysts, those professionals will work with all children. And so you don't need to have a diagnosis to see a behavioral analyst. I think I don't know why it's sort of a hidden secret in terms of the supports that these folks can provide. In some ways, I think some of this behavioral, we're often very focused on nutrients, right? But eating is so much more than nutrients. To get those nutrients in, there's a lot of behaviors that have to happen first and a lot of skills that are needed. So I think we need to work to highlight that that's a care option better. In terms of what a behavioral analyst will do is they will meet with yourself and any other caregivers that are involved in feeding or taking care of your child. And they'll ask you all sorts of questions about your child's medical course, about challenges to date in terms of feeding or eating skills. And they'll ask you about your home environment, like how you set up meal times, where the child eats, who eats with the child, all sorts of questions about that. And then typically some of them will actually watch your family. So they may set up a video camera, or maybe they'll join you for a meal and sort of look at those interactions and have tailored approaches for your family in terms of what will help your child as an individual. And so it typically, there'll be lots of interviewing before, or sort of chatting before some of the actual interventions start, but they will be tailored to your child. And so some of the interventions that the behavioral analyst will work on, some of them are environmental. So thinking about eating at a regular time, at a regular spot with appropriate positioning for your child. But then some of it will be in like helping your child through different textures. So, and giving rewards when your child tries a different texture and progresses through, from puree to mince to soft and then full foods. They might work on presenting foods in different ways, like cooked versus raw. And there's a lot of rewards that go into the behavioral analyst approach. And so we really try and reward the child for that preferred behavior and ignore the non-preferred behaviors, which I think is key, because it's hard when when your kid refuses food that you've cooked, right? And you're so worried, and feeding is love, and it can be so tough. And so often we react very strongly to those negative behaviors, but that gives the child, a reaction. And not that they're looking to get you mad. That's not the point, but they're looking for interaction a lot of the time. So and kids are quite crafty. And so if they refuse something and then get their preferred food or, drink or whatever it is, that's powerful to them. And so thinking about not reacting to those non-preferred behaviors. So the behavioral analyst really looks at your family holistically and all of the caregivers in a child's life to support in the best way possible, really practically, I think.
Wow, that was great. One more question about the peer pressure when the kid is in daycare setting or going to school. Is there such a thing as peer pressure if they see the friends eating certain foods that they want to try those foods? And I think a lot of what you're saying is applicable to all children. Mm-hmm. Right? Obviously, our preemies have some extra challenges, but a lot of what you said, I see my friends with term babies also struggling. But the peer pressure piece, how does that play a role in the feeding?
Yeah, it's so funny that you bring that up. It certainly does play a role. So in my research, a lot of what I do is I actually videotape families. And so I send cameras home to families' homes and I look at those parent-child interactions. And so I had a study a few years back where families did that. They recorded their meal times. And then I had a similar study going on at a childcare center where we were looking to validate something related to what the kids' menus were. But it was quite funny because there were overlap in terms of the children who were in my study who were also over in this childcare center. And at the childcare center, the kids would eat the meal that we were observing them watch at daycare was it was salmon and broccoli pieces and like a glass of milk or something. But it's very funny because the same kids at home were, some of them were offered fish at home and would not touch it. And then I see these same kids in daycare and they're just gobbling up their salmon. And so I think there very much is that peer pressure that goes on in terms of wanting to be like our peers. And so sometimes daycare settings can be really beneficial. And so I encourage you, as your child is safe to try those foods at daycare, allergy-wise and swallowing-wise, don't necessarily give the daycare caregivers a heads up that your child is, selective in their food choices, because we want to allow them those opportunities to be offered the same foods as their peers as they're able to have those foods. So it certainly can be beneficial.
That is a great tip, actually. So one last question before you wrap it up. You talk about tongue tie. If the baby did not have a problem breastfeeding, but now is into having some challenges feeding solid foods, can it still be a tongue tie issue?
It could be. They're typically like some children with tongue ties, they don't have symptoms early on for a variety of reasons, but as they grow, either the tongue tie diminishes because their tongue and their mouth just gets bigger. And so that actually resolves. But for some children, it just based on the way that the spoon and the way their tongue needs to move to take food off of a spoon or a fork is different than feeding at the chest or breast or at a typically babies that are fed at a bottle don't have issues even if they have a tongue tie, but so it can still be potentially an issue. And so I think it's just one of those things that I don't think it hurts to ask your healthcare provider, like, can we take a look? Do you think this is a concern?
Absolutely. Okay, Dr. Walton, thank you so much for joining us here today. I'm looking forward to talking to you again and see what else is coming out of your lab. So thank you so much for joining us.
For sure. It was a pleasure. Thanks so much for all the great questions. And I look forward to coming back at some point.
Yes, thank you. And to all of you watching us live today, thank you so much for joining us. And the video of today's session and all the other videos from our Preemie chat series is available on our website, which is right here, the Canadian Preemies.org. And I want to thank our sponsor, AstraZeneca, for their ongoing support of our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensure they're ready to care for their baby. Please visit our website and consider making a donation. Together, we can create a brighter future for all our families. And I'll see you again next Friday, 1 p.m. Eastern Time. Stay well.